Hello, everyone, and welcome to day 2 of the Nuffield Trust Summit Series. My name is Sarah Reed. I'm a senior fellow here at the Trust, and I'll be chairing the conversation we're having today, where we'll be discussing a new report we're launching, looking at how other health systems have been dealing with backlogs, how they're approaching recovery, all the lessons we might be learning or unlearning, and what a disaster-proof health system might actually look like. To help me do that, I'm really pleased to be joined by such an exciting panel of experts. With us today, we have Maya Matthews, who has been working in public health for over 25 years. She's currently head of the Performance of Health Systems Unit at the European Commission, and she's had a front row seat this past year at reviewing all the different plans EU countries have been putting forth on how they're seeking to develop and recover from the pandemic, including in health. So really thrilled to have her with us today. We also have Dr. Ewout van Ginneken, who is the coordinator of the Berlin hub of the European Observatory on Health Systems and Policies. Him and his team have been helping us monitor and track and understand how health systems have been responding to and are now recovering from the pandemic. We're thrilled to have him. And then last but not least, we have Dr. Jorn Christensen, who is the Chief Medical Officer at Aarhus University Hospital in Denmark, a health system with some really interesting similarities, but perhaps striking differences with that here in England. So hopefully we'll get to compare some notes about how our respective countries have been faring in recovery and what we can learn from each other. But before I do all that, I first just want to say a few words about the summit and the session overall for those who might be less familiar. So the Nuffield Trust, for those who don't know, we're a health policy think tank. We look at a wide range of issues in health and social care policy. And with our summit each year, we try to provide some space and time out for experts working in healthcare and policy to be reflecting on some of the biggest existential questions of the day, and there's certainly many at the moment. This is our 14th year hosting the summit. It's our second of it being online, maybe our last of it being online, we don't know. But today, during the summit, we'll be exploring all these questions from an international lens. So this morning you have me talking about recovery and backlogs, but this afternoon turning to an equally pressing issue on how we can get health and social care integration right once and for all. So do encourage you to join us later if you can. We're really grateful to everyone who's been doing so much to make this series happen, in particular our sponsor Optum and our partner, our media partner, the BMJ, and just everyone who's been working behind the scenes. So thank you very much to them. And as for today, I'll be chairing the conversation, but would really love it if all of you got involved. So please do be writing in with your comments, reflections, questions using the Q&A box. I've got staff here on hand to help me moderate that, and we'll be bringing them in throughout the conversation this morning. And speaking of being involved, please do tweet liberally. Our hashtag for the day is NT Summit. So we look forward to keeping the conversation going during and after the session today. So before we dive in, though, into that conversation, I just wanted to spend a few moments to set the scene and talk through some of the key findings of the report that we're launching today. So I think I've got some slides that will be pulled up now that you all can see. But just to say, so yes, in terms of the research we're launching today, so this is based on 6 months of work we've been doing at Nuffield, where we've been talking to over 40 different experts in 16 different health systems across the OECD and EU to try to understand how backlogs have been affected by the pandemic, what are some of the common challenges and issues that countries are going through, where there might be practical learning for the NHS as we approach our own approach to elective recovery, not only to catch up on services as quickly as we can in the aftermath of the pandemic, but also how health systems might be thinking differently about some of the structural weaknesses and challenges that have been exposed or worsened by the pandemic, and what countries are doing now to help place health services on more sustainable footing moving forward. So the report and this conversation today are very much focused on these questions here of resilience and recovery. So what are health systems doing now to build back from the pandemic? And we see that as distinct from response. So all the interventions and strategies that countries might have gone through to build surge capacity during peaks of the crisis and to deal with the demand from COVID-19 patients. Of course, there's a real overlap in what some of those strategies and interventions will have looked like across these different themes. And certainly the path from response to recovery has been far from linear, not here, not elsewhere, but this is really where we're focusing the conversation today and in our report as well. So that first exam question then that we had was just looking at, what do we know about the scale of the recovery challenge and other questions? What can we say about backlogs and how they compare? And the first thing I would say there, though, is that that's a very difficult question to answer, particularly at this moment in time. So for one, the pandemic isn't over yet. So how resilient health systems have been is still something we can't answer fully. And at the same time, the indicator we would want to turn to try to understand how things like backlogs are comparing would be wait times. But there are many differences in how countries measure waits, what they measure, whether they measure waits at all at the national level. So that can make having a direct comparison and view into that quite a challenge. Where there is standardized data, it has, really only available for 2020. So we don't fully know how that's evolved over the course of the pandemic. But in our report, we've tried to draw on national data wherever we can get it to help build a picture of how countries are faring and where there might be some common challenges in recovery. So while the question is hard to answer, though, there have been some interesting trends and patterns that have surfaced that I can just mention briefly now. I mean, the first thing to say is that no health system we looked at was sufficiently prepared to completely avoid disruptions to care during the pandemic. So in every country we looked at, elective and routine services were disrupted at some point, either because out of precaution and steps countries took to help avoid transmission, or because services had become overwhelmed. So even though it's a fairly universal problem, in many countries, more patients are waiting longer than they were before. There are some interesting variation that we can start to see. And that's a bit of what this chart is trying to do here on the slide. And it is using EU data, so unfortunately the UK is not included in it, but I think some of the challenges with our backlog have been fairly well documented. But here you'll just see, on one end, we've got some countries like Austria, Denmark, Germany, where it's about 10 to 15% of patients that have reported some difficulty accessing care, some degree of unmet need during the pandemic, as compared to some other countries we looked at, like Spain, Portugal, Ireland, where that's more around 25 to 35%. Where there is variation, unsurprising, it's been that countries that have been better able to control COVID-19 transmission have seen less marked increases to their wait times. That's something that we see in countries like Australia, Finland, and Denmark. And some countries that entered the pandemic where waits were already a problem. So similar to England, but also Ireland and Sweden, we've seen those wait times accelerate further. And patients who were waiting before are often waiting now, and the proportion of patients experiencing very long waits have grown in some countries. Where there have been increases, we've also have tended to see it concentrated among less time sensitive or urgent elective procedures, so things like cataract surgeries or hip replacements, but that's certainly not universal. In lots of countries we looked at, things like cancer, even though there was direct policies and intention in lots of countries to protect access to those services, those have also been disrupted. We've seen that a bit play out here, but also in countries like Italy or France or Spain, similarly reporting lower volumes of treatments or diagnostics or referrals for cancer in the 2 years of the pandemic that now need to be caught up. And the last thing I'll just say here is while we're starting to get a picture of what these challenges look like, a lot of countries we spoke to have said that there's just still a huge unknowns about what the scale of the backlog will be because of this fear around missing patients. And that is something we've seen discussed in our own context, but in lots of countries, things like diagnostics and referrals and GP appointments are still lagging what they would have been before the pandemic. So there's a fear that these patients will be added to the wait list at some point, and it's unknown about what condition they will be in. So it's just really hard to predict, and that's something a lot of health systems are having to grapple with. Moving on then so what have we learned then about how countries are approaching resilience and recovery in the aftermath of the pandemic? I think one thing that has come through really clearly, and this might not be surprising, is just how much capacity does matter. So in lots of countries we have been speaking to, there's a debate happening about how do we get the balance right in a health system between efficiency and preparedness. And you'll see here on this chart, the UK there along the top line, that the NHS has entered the pandemic with very few advantages when it comes to the resources it had to cope with the pandemic. We have fewer levels of staff in key areas, fewer numbers of beds, higher occupancy levels, lower levels of spend, and all things held equal. Countries that had more capacity and headroom to keep both COVID and non-COVID care running during the pandemic, and indeed keep up with demand before the crisis, will likely be in a better position now to cope with the consequences of COVID-19. But with that said, I think it would be easy to draw premature conclusions about what health spending should look like now in the wake of the pandemic. A lot of variables are at play that we need to understand a lot better before we can make such a calculation. But with that said, I think the one thing that has come out in our conversations is that it would be grossly inefficient for health systems to plan every day as if to deal with a pandemic the size and scale of COVID-19. But at the same time, it's probably equally ineffective to plan healthcare spend so that health systems have difficulty absorbing a shock of any kind, and indeed aren't able to keep up with more anticipated or routine pressures like winter year on year. And this is a debate I know we've seen happen in the UK, but it's also happening elsewhere, where lots of policymakers have told us they're thinking about, what have this historical focus on cost containment, what has that meant for preparedness? And it's not just about level of spend, but how those resources are distributed, and thinking differently about which assets might need to be fixed versus flexible in a health system. Moving then, another key theme that came through really strongly in our report is about workforce, and it's really impossible to talk about capacity without talking about staff. In every single country we interviewed, workforce pressures were referenced as being the greatest risk to recovery. And health systems are doing lots of things in the short, medium to long term to try to address some of those challenges. While a lot of health systems saw their overall staff numbers increase to be able to deal with the pandemic, there's still lots of very serious fears about retention and more staff leaving the pandemic as they're more exhausted and burnt out than before. So the report goes into full details about what some of those solutions and strategies countries have been turning to, and hopefully we'll get into that in our discussion later with our panel. But just to say, this is a really intractable challenge, and it's one where I think a lot of health systems fear that what is being done in the short term to be able to deal with backlogs, extending hours of care, there's a risk that might further burn out or exhaust existing workforce and threaten resilience and sustainability moving forward. And then I'll move to our last lesson or theme that came through. It's just that when we're talking about these things in capacity, it's not just in hospitals. We were really struck in how many countries we spoke to, when they're talking about elective recovery, they're really thinking about it holistically and how the different sectors of health and social care interconnect with one another. So there's some examples there on your screen here about how countries are making investments and thinking about capacity in other areas outside of hospitals to bring down wait times. But it's certainly a common theme we heard, that if we're going to recover elective backlogs, we have to do that while recovering general practice, while community services, social care, mental health, emergency care, all at the same time. So that is simply just, I think, a taste of what's in our report. And again, the report will have a lot more practical learning of what some of these solutions and strategies really look like. And I think we're going to get into that now in the discussion. But if I can, I'll stop showing my slides, and I want to bring in my panel for their thoughts and reflections on all of this. And the first question then, maybe we could go back to the beginning, and I'll start with Ava. I'm just curious, in the media here, at least in the UK, we hear this conversation around backlogs on an almost weekly basis with real concerns around wait times. And I'm just, from your view, how much are we on the same boat together here? What is this challenge looking like in other countries, as far as you can tell?
Well, thank you, Sarah, also for inviting me to this important event. The challenge is largely the same. I mean, of course, countries are affected to different degrees, but all the challenges that you mentioned in your introduction, basically to some role, are visible in other countries as well. So the big challenge on the short run is to how do we tackle the backlog? And, we don't know the exact backlog. Just think of, for example, the missing patients, the people who we expected to present during the pandemic but never did. Will they show up later with worsened conditions? We also will have perhaps a new demand, for long COVID services. So there's a lot of uncertainty, which makes it, of course, difficult to plan. And as you mentioned before, workforce is the issue in virtually all European countries. And how are you going to tackle that? The workforce is already overstretched, I would say, in many countries. I mean, there are differences. I think we'll get to that later. And you can only ask so much from the workforce. And we will be asking more from them if we want to recover. You cannot just simply go to pre-pandemic levels and think that the backlog will disappear. In many countries, we will have to do more. So that is, I think, an important thing to realize. It also means that given how difficult the workforce situation is, that we need to think about new models of care that you also rightly talked about. More primary care in the community, really care focused on keeping people out of hospitals, better managed chronic diseases. So I think with better, flexible staffing models, you name it. I think this is what we see all over Europe.
Thank you. And well, yeah, we'll definitely get into some of those issues you raised, I hope, as this conversation goes on. Maya, I wanted to turn to your view on this. I mean, walk us through it. What are things looking like to you? What are you hearing from other countries? Is the recovery challenge looking similar, different? Is there variation? I mean, what's coming through?
Well, thank you very much, Sarah, and a big congratulations to you and your team on the excellent report. Yes, I mean, we are also at the EU, as you said, we have this kind of helicopter view. We work very closely with member states, and we've worked also with Ewout and his team at the Observatory and the OECD to produce 29 country health profiles, so the 27 EU member states and Iceland and Norway. Unfortunately, we don't have a country profile for the UK. And from those 29 profiles, we were able to bring out kind of 3 takeaway messages or 3 takeaway, basically the things that really struck us. As you said very rightly, all member states started from different starting points. They had different issues and challenges within their health systems. But now looking forward, I think that firstly, we, as Ewout said very well, we're still going through the transformation and the pandemic. So we still need to understand better the effects that this pandemic will have on health, on people's own health, but also on health systems. And as Ewout said now, all sorts of strange side effects. We don't really understand this virus yet. We don't really know the long-term consequences. There's also the huge mental health issue, and there I think it's very important to put broad attention on that. And then, as you said, the other thing is how we're going to deal with the delayed or foregone care. I must say, in many countries in the European Union, there was quite a quick bounce back. So after the peak of the pandemic, quite a lot of the countries were able to bounce back with levels of screening, for example, cancer screening back to the way they were. The second big takeaway we had was also kind of grasping these new delivery models, this huge acceleration of e-health, teleconsultations, but also very importantly, how data was managed. I mean, I would say that one of the very key things that have come out of this pandemic is the importance of data. For example, I said, I think it was in the UK, but also in many other countries, I mean, epidemiologists became rock stars during this time. And so this is something I think as well that all member states have to really, all countries have to look at how we collect data, how we share data. Obviously within the EU, we're looking at interoperability so that we will be able to have much more integration, that we will be able to share information like, ICU beds availability, things like that, so that we can work together and provide solidarity. And then, of course, the third one, I think, speaks volumes, workforce. In all of the countries, that was the main stumbling block to being able to deliver care for COVID patients. I mean, it was a really big issue, and I look forward to discussing that further. And maybe just on one last point that I think you mentioned briefly, but I think is also very important, is the importance of investing in health. And I think the fact that health has been on our screens, on social media, everywhere for the last 2 years, it's really put a big attention on long-term investment in health, and also public health, because public health has also, I'd say for the first time in many years, been put in the spotlight. So people hopefully understand better what public health is, that you need surveillance, you need track and tracing, you need rollout of vaccination programs. All of these kind of things are very important for preparedness so that we can be able to respond better when the next health crisis hits.
Thank you, Maya. Really helpful reflections there. And again, we'll get into some of those, I think, as the conversation goes on. Björn, I wanted to turn to you. Of course, Denmark is a country that has had a really different experience with the pandemic than we've had here. But of course, I know the government there also made similar decisions at certain points to defer or cancel some elective procedures, at least early on in the pandemic. So, backlogs and things did accumulate. And I'm just curious, and of course, the latest wave will have also had an impact. And I'm just wondering, can you walk us through how things are feeling now in Denmark? What's the recovery conversation like? Are backlogs kind of dominating the discourse in the same way as they are here?
Thank you for having me, and thank you for the question, because I think we have some interesting views on the pandemic, because we were in a lucky situation before the pandemic that we had relatively low backlogs because we have a lot of national key performance indicators for cancer and heart diseases, and a 30 days for diagnosis and treatment for all diseases, which keep us on the toes in the health system. And we've been through a period of reduction of the number of acute hospitals. We only have 21. And luckily, we had the opportunity to rebuild or new build 16 of them for the last 10 years. So our infrastructure is relatively new, which helped us, together with what Maya mentioned. We have a huge national data platform and we are heavily digitalized. So that certainly had major positive impact on the process. But of course, we had to make a major backlog during the process. Luckily, we could reduce it between the second and the third wave. So now we have a backlog on about 100,000 operations, which is around 1 month of work for the hospital system. Mm-hmm. And as you mentioned, Sarah, one of the helpful things was very early lockdown in the country, 12th of March, total lockdown. And we have had less COVID than many other countries. Mm-hmm. And combined with a very high uptake of vaccines, we were over 90% of the citizens offered vaccine who actually took it. So the combination was positive for Denmark, and still we have patients waiting, and still we have staff who are tired of the whole process and so on.
Mm-hmm. That's really interesting. And so I'm struck by some of the issues you were starting to raise around kind of capacity and what that looks like in Denmark. And maybe we can pivot into a conversation now more on that. So it sounds, Denmark, very interesting to have reduced the number of hospitals and beds, but you have kind of modern, flexible infrastructure that might, that proved as an asset during, it seems, parts of the pandemic. And I mean, Eva, I wanted to go to you now. I mean, just to put it really bluntly, I mean, do you think the UK would have the backlog it has if we just had the same numbers of staff and beds as Germany? How much would that really help us? And what lessons do you think we should learn or not learn about capacity in a health system and what's needed moving forward?
So my short answer is yes, that would have helped. Indeed, your situation would have been better. You would probably not have had so much, waiting times going into the pandemic. You would have had more peace of mind through the pandemic because people, there was more capacity to treat people. And, this is a big difference I see, for example, between the debates that you see in the Netherlands and the UK, where there is, a lean model compared to Germany. In the Netherlands and the UK, it's always about bed capacity, and in Germany we never talked about it. So it made sure that there was peace of mind. I think that there was enough capacity, but it's also too easy, as Jurjen's example showed, the Danish example. It's a country with similar numbers of beds as the UK, and they didn't get in those kinds of problems. So it shows that yes, capacity plays a role, but I think perhaps even more also important going forward is having this public health capacity to better contain a pandemic, that's one thing, but also better use of resources, better spreading of patients where possible, using capacity we have, more flexible models of care delivery, and not too hospital-centric response. I mean, even in the UK, I think the response at the beginning was quite focused on hospitals, whereas in Denmark and other countries that was probably much more also in primary care. And this is also often, I think, the misperception in Europe that it was all about the hospitals. No, it was also really important what was happening in primary care in the community. So I think that the answer is not simple, and we need to look at all of these things. I mean, I love the Danish example where they exactly know where patients are because they track them through the system. This is not possible in most countries, and that's something to start with. Indeed, better IT systems, something that Maya also alluded to, will be incredibly important to first, use the capacity we have and become a little bit smarter.
Absolutely. And I was so interested in some of the conversations we had in Germany as well. Even with all the beds and nurses, there wasn't enough capacity because on paper it looks like there's quite a lot, but it wasn't in the right places. It wasn't necessarily in intensive care. So it goes to show how it's really complicated when you look underneath the numbers sometimes.
Maybe a quick addition. That's very true. I mean, although there are many beds in Germany, the problem in Germany is probably that there are enough hands on those beds. So in the end, the bottleneck was much more the workforce, again, as in many other countries. So in fact, perhaps they didn't have all that capacity. So that's also something you need to realize when you plan.
Great. Maya, I was wondering if I could turn to you on the same question then. I mean, what's standing out to you in terms of how countries might be thinking differently about capacity then? Do you see anything coming through in the plans, where are investments being made or how are resources being thought of differently, if at all?
Sorry. Yeah, I was very inspired by what Ewout said, and so I would like to follow up on that about the fact that I think now it's a pivotal time to actually look at skills and skills around the health workforce. I think as Ewout gave a very good example about Germany has the highest beds in Europe. We all know that, but you didn't have the people because a lot of health professionals were not trained in intensive care work. So within the EU, what we did with the European Intensive Care Society is we funded a kind of virtual training program on specific skills for how to work in intensive care units, and this made us think very much that I think that the whole health workforce needs a huge rethink about what kind of skills are needed, and I hope that also by doing this it will also attract more people to the professions. What we're seeing, and I wanted to share this we have very close contact with many of the professional associations, that actually there has been an increase in applications to join different health professional specialities. But after the first few years, there's a high dropout rate. So I think it's really important to try to focus and find out and unpack a little bit about what's going on there, because I think there's lots of things happening at the same time. We are going through a massive transformation, and that's very difficult to kind of track what's going on. But I think this whole area now, if we talk about capacity and we talk about the health workforce, if we try to talk about it in terms of skills, what's needed, it could also be a way to also look at the whole digitalization. I mean, things have changed a lot. The whole patient professional relationship has changed. I mean, we had lots of very interesting discussions about the use now of digital tools, the empowerment of patients, and the questions that patients will ask, and our GPs, our GPs trained to do this. We had some very interesting discussions with the European GPs associations, who said that actually what they need is training on those kind of issues, on how do you steer a conversation with the patient when they are sometimes really technical IT based questions about the gadgets that they're using. So I think that in terms of how we go forward, I think we all recognize the huge importance of focusing on the workforce, but we need to build a workforce for the future, not a workforce for today. And I think that's a huge policy. That's one of the biggest challenges for policymakers today. What will the health workforce of the future look like? Because there's no point training people for what we are seeing today.
Thank you, Maya. I think a really important point, certainly, to have in our minds as we talk more about workforce and workforce planning and what's required for resilience versus just recovery. Jörn, I wanted to turn to you because one thing, this picks up on comments that both Eva and Maya had made, but on paper, the UK and Denmark don't look terribly different. We both have about 2.5 beds per 1,000 people compared to Germany's 8. We spend similar in terms of our overall percentage of our economy on health, but yet I'm not hearing you say that backlogs are as massive as a problem, going into the pandemic as well as on the other side of it. And I'd just be interested in your reflections. But I know Denmark has a very different workforce situation than certainly the UK and lots of other countries we're looking at. And yeah, could you just say about, what do you think explains our different experiences when it comes to wait times and backlogs? What are some of the compared advantages you think the Danish health system had going into the pandemic?
Thank you. I think one of the advantages was actually a national focus on reducing length of stay and key performance indicators for all the hospitals, which we are highly responsible for cancers and all diseases. That motivates us to do our best. And the second is we have a proportionally large number of doctors and nurses per bed, resulting in a very low length of stay. So we have one of the shortest length of stay in the bed, and it correlates actually with the number of doctors per bed. OECD has published that earlier on. So I think one of our advantages was relatively many doctors and nurses who were skilled, trained, working on a daily basis, which could be used. And we were lucky to have the community being able to take over patients after hospital stays, because that's how it is every day. So we don't have patients in beds who should be in the community. So, and I'm afraid to mention the numbers, but we have actually in the OECD report seen that the numbers and doctors in Denmark per bed is close to 3 times the numbers in Germany. So we have a huge workforce of skilled nurses and doctors compared to, example, Germany.
So that might be one of the secret ingredients, it sounds like, having staff to help support patients better through hospital and a place to send them in the community, perhaps. I'm curious, let's talk then about workforce, I guess, a bit more directly then, and maybe hearing from Jörn how Denmark got there, because I think of all the things we've discussed so far, I do really fear that this is a place where health systems have some of the biggest challenges in recovery, but perhaps the least number of options on what to do about it. And it's something that funding, at least in the short term, won't easily fix. So in that context, I mean, what are some of the solutions and strategies that health systems are turning to? And maybe Eva, I'll turn to you, because I know this is research that you've done and looked at directly across EU. Anything giving you hope about what other countries are doing now?
Yes, I think there are important developments visible. I think that can help also alleviate these pressures. Although the markets, the labor market situation is incredibly difficult, right? So, we should, but there are some. What we've seen is that countries really try to support workforce as also as a way to retain them, and also not for people to drop out, which we have seen also quite a lot actually in Europe, by simple things perhaps, like making sure that there is childcare maybe on site, parking, to give them a parking space, or to help them with transport, doing their groceries. There have been incredibly helpful examples, just so that people can focus on their work. One of the things that we've seen too is in some countries, often also developments that we've seen before, but I think we need to accelerate, are the skill mix innovations that Maya also talked about, because they can also make the profession more interesting if you have more skills, more capacities, more responsibilities actually. So that could of course help too, because you will need to recruit people, which is of course difficult. There are a couple of things you see. I know that the UK is now pushing for international recruitment. This always needs to be done really carefully. You don't want to recruit from a country that has shortages themselves. Within the EU, obviously, there are slightly easier ways, I guess, also for people to move between borders and work in different countries. So I think that some kind of a European response could perhaps be in order. And what we also shouldn't forget is that, this is again the broader capacity issue here, is that you can also think of the opportunities that there are with cross-border care, obviously, to alleviate pressures on the workforce, as we have seen during this pandemic. Many patients from from the Netherlands, from France, have been treated in German hospitals at the height of the pandemic. So there are various things possible. Of course, also financial incentives play a role here. They are well deserved, and we should think about what is the appropriate pay for health professionals. I think this is a discussion that you see in many countries. But also with pay, you will not solve the long-term, I think, challenge that we have.
Thank you. And yeah, I think your point on skill mix is a really interesting one, and it spoke to something you mentioned, Maya. I think I was really struck when we interviewed different health systems. I mean, I remember some hospital systems in Spain saying they just simply do not have enough anesthetists to keep up with surgical volumes to clear the backlog, and it will take a long time to get the numbers they need. So what they've been doing, this is very staff-led approach within hospitals, but nurses with those relevant skills have actually been taking on more of the responsibility to administer and monitor sedative medications, things that they weren't really doing before, but are perfectly trained to do in that context. And was a way that was helping the team kind of get around some of the challenges of the backlog. So I think there have been interesting innovations there. I mean, Maya, I want to ask you this. I know something that you've been looking at as well, and you've mentioned, but I mean, will any of this be enough to help them retain the staff they need? I mean, what's giving you hope? Is there a health system out there doing workforce planning really well? And maybe we'll hear from Jørn about if Denmark is the example, but what are your thoughts on this, Maya?
Yeah, no, it's a fascinating discussion, and I think the last 2 years have put it all into really strong focus, because what we know, I think we need lots of different. It's a multifactorial issue, and we need to address it from many different sides. I'd say for me the biggest one, and this is the one I think is the hardest nut to crack, is actually there needs to be more prestige around it. We need to attract more people to the professions. And that's why I was saying in my previous speeches that we need to look at, we need to address it differently. I think we still have kind of quite a traditional approach to the different professions, and that's why I think the whole discussion around skill mix and clinical, non-clinical, the whole health ecosystem. I know that sounds it's a cliche, but there's so much happening in health. And I speak to young people. I have trainees, and I ask them all what they want to do afterwards, and some of them are clinical professionals who then have decided not to go into a hospital or into general practice. And for me, that's the key, is that we need to find, it's the working conditions, it's what makes people tick. It's all of us, what is our motivation? And a lot of it is about the satisfaction you get, how well you're rewarded, how you see your future. And so I think apart from these quick fixes that we've seen during the pandemic about, bringing medical students in early to do things, bringing retired people, there needs to be a much broader discussion about, how do we encourage more people to work in this? And if we're going to encourage more people, we have to also provide them with good working conditions. So it's a huge discussion. I mean, within the EU is like a natural laboratory because we see all the differences. And in the document that I mentioned in the report that we did, and I can put the link in the chat, we looked at the kind of doctor-nurse ratio in each country, and there's absolutely no trend. There is nothing. You can't even try. My poor colleague, he spent ages trying to figure out, was there anything we could say? No, because each country is a sovereign nation. Each country decides how much they're going to pay their doctors and nurses. That's something, and I want to make that very clear, that's for each country to decide. So from the European Commission perspective, all we can do is really demonstrate the evidence, show the information, and bring member states together. And so that's what we're doing, for example, on workforce planning, is that we're bringing together a project with member states to discuss amongst themselves, what is the data that we need, what are the kind of issues to plan. And so we hope that by doing that and sharing best practice, we'll be able to have a little bit of a clearer view and help member states really in this very, very difficult task.
Thank you. And Jørgen, I might give you the last word on workforce. Of course, you didn't go into the crisis with similar pressures, but I know Denmark is one of several countries that we've come across where nurses actually went on strike during the pandemic over works and conditions and pay. And I'm just curious, what have been some of the takeaways and learnings there? How is the system working to move forward from that and address some of those concerns?
I'm sorry to say we have the same problems as all other countries, especially on nurses, not on doctors and others, but especially nurses. And we are fighting to give the prestige back to being a nurse in a public health system. And we're trying different things like digital onboarding, being more digitalized in the recruiting and retrainment process. And I think one of the things working for us is actually when doctors and nurses work as a team. So trying to encourage even more teamwork is good. But we are still struggling to retain nurses in our system. And the strike was actually not made by the COVID situation. It was just the regular 3-year agreement between employer and staff nurses about payment, but it turned out to a 10-week strike last summer, which was a disaster for recruiting more nurses, because it's kind of made it public that perhaps they would like better working conditions and better salary. So we do not have a solution to it. We're still working on it, but there's a relatively large number of nurses going around who will not be working as a nurse in the ward system, at least. And we realized we had a huge vaccination center with hundreds of staff, not from the hospital, from the outside. And suddenly we saw 80 nurses working there. And we tried to recruit them to our hospital. And they won't take a job in the hospital. They are lucky doing like vaccination, going to some small private clinic, doing whatever. That's a major problem. We haven't solved it.
Thank you. Well, I guess reassuring that we're not alone in this, certainly. And I was, if those who listened yesterday, I was really struck by, Amanda Pritchard spoke really thoughtfully about some of the things NHS is doing as well to try to work through some of these shared challenges. But there's just no getting around what a huge, enormous problem this is. I want to now just turn to my colleagues to see what questions have been coming through the audience. And I might have a question to close us all up with, but maybe if I could bring my colleague Mark up, who's been helping me moderate all your thoughtful comments throughout. So Mark, if you're with us, what is some of the things the audience would like to know that we can turn to?
Thank you, Sarah. Well, we've had a lot of brilliant questions coming through, which I don't think we'll be able to get to all of them. So apologies if you've you asked one, but I'll try and cover the ground that people have been interested in. I think we could start with a question we got from Adriana Castelli at the Centre for Health Economics at York University. She asks, are key performance indicators the solution to getting the backlog down? It may work for Denmark, but is it a model that can be transferred to other health systems?
A very interesting question. Yeah. So what role do targets, how helpful are those? I would love to know your views. I mean, Jörn, you gave a bit of a perspective on that, but Eva, do you want to say anything perhaps around the role that the performance targets and measures have in helping us work through this challenge?
It's not only, I think, really about perhaps motivating people, but it's also really to know what's going on. And so to be able to also use the capacity at hand and perhaps more actively steer and use those resources that are perhaps available. So I think that good data and performance indicators are incredibly important, but there are also limits to them, which have been discussed here also as well. And they will not be the magical solution for structural problems that basically all health systems in Europe now see. All the inefficiencies, all the gaps have been laid bare by this pandemic. So just having great data and performance indicators just will not change this immediately.
I think very fair. Well, there's never one solution to a problem, is there? But I think I was struck, maybe naively, but there are just many health systems that don't really measure waits or backlogs at all. Probably due to how those health systems are designed differently and far more localized in nature. But just even getting a sense of what performance is like in some of these areas isn't straightforward in lots of places. And I think something that can be, I can certainly take for granted being within the NHS system, where we just have a much different approach to data and have a real full sense of some of the challenges. Mark, are there any other questions on that, or otherwise we can maybe take one or two more?
I think let's try and cover just the broad range of topics people have been expressing interest in. We've had one from James Maddox at the NHS Confederation, who asks, on data, the UK has well documented problems in building trust among the public towards data collection and reuse. We've had successive efforts to get a database of general practice activities together, in particular, really undermined by public backlash. He asks, are there examples from other countries about how trust in data reuse has been built before or during the pandemic?
A really good question, and maybe Jörn and Maya, I'll get your views on this. There are health systems where I think, patients are given a lot of choice around waits. You are able to use that data to be able to select to receive care outside of their local area if they have to wait beyond a certain threshold. But that requires a lot of trust to have a system implemented with that data. I mean, Maya, do you have a view on this question of data and trust? How does it sound from your perspective?
Yeah, no, I think it's key, and the way we're approaching it at the EU level is that we're putting the secondary data hand in hand with primary data, because I think that what's important is to first give people access to their own data. So we're building something called the European Health Data Space, which is it's a new proposal that we hope to be adopting later on this year in the spring. And the idea is that first give people trust. The way to build trust is for people to actually see that it works. So the idea is that people will have access to their own health data, that they will be portability, so they will be able to travel with their own data. So if they want to go to another country to seek care, they will be able to take their medical data with them. And then as a secondary, then open it up to reuse. But I mean, it's incredibly difficult. I mean, there's loads of issues, of course, around data protection and privacy. But I think that's the way to do it, that, you can't ask people to release their own data when they actually don't have access to it themselves. So that's the way we're approaching it.
Absolutely. And I know in our report, we talk a lot about kind of the different approaches to data and where there's been some really interesting examples. And just for those who might not know, I think we sent a link to the report in our chat, and it will be available to download on our website. So please do refer to that later. We'll make sure you get a copy after today. But Jørgen, I want to know what data is like in Denmark. I think Denmark is often held up as an exemplar, but how do patients hold and understand their data? How does it work when it connects to weights? Can you walk us through that?
I think we're lucky to have an enormous amount of trust in the public health system in Denmark, also regarding data. And as Maya mentioned, it's critical to give the data back to the patients. So we have a national place where you can go and, as a patient, and look into your healthcare data from your GP, from the hospitals. You can see the notes, you can see the X-ray descriptions, the pathology. It's actually overwhelming sometimes, but you can access it shortly after it has been produced. And I think that's very helpful in building trust, giving access to patients to their own data. Then we have had a major public discussion in Denmark about healthcare data and secondary use, and we have built numerous national health data structures, and we have one national health data registry which collects all the data actually which is available in a huge database, and people actually do trust it, but we have to work with it all the time. We have to look at the GDPR rules, but it's going okay. But we would like to move further on, trying to have even more data like patient-reported outcome data in a larger extent. We are working inside the EHDS and the health outcome observatories in the EU to try to do some of it. And still, it's interesting that some people are not trusting systems about their healthcare data, but they give the same data and even more private data to the Google and Apple and the media, which is it's strange. So I think trust is there. We still have to work with it.
Absolutely. And I know we've just spoken a lot about kind of the patient relationship with their data, but I was really struck by just even where there was such data constraints in other systems about even knowing where beds are, where capacity are to be able to shift resources quickly during the pandemic. I mean, that's something where the UK might have had a comparative advantage given kind of some of the centralized nature of our data sets. But certainly, I think there'll be lots of different thinking and approaches to data and how we use it to inform decisions and health systems planning and delivery moving forward, both with the patient and kind of across providers and other parts of the system as well. Mark, how about I come to you for one more question if we have time, and then we can start wrapping up.
Certainly. Thank you very much, Sarah. And just before I do, I know we've had a few queries about links to our report. Is very flattering, very welcome. Just said we have a link in the chat that you should be able to see, and also people can download it from the resources section of the StreamGo platform that you're looking at. I think for our last question, take one from Tasneem Muinikbal at NHS England, who has asked, how can health services best balance recovering the elective capacity and addressing the backlog when we still emerging against building resilience in urgent care?
So I feel like this is a huge question, and I think something that all systems are grappling with. Ava, maybe I'll start with you if you want to give it a go.
Yeah, well, this is the key question, no? I mean, how are we going to do that? I think that we still need to control the pandemic. We need to keep that under control. This is still the best backlog policy, to keep those numbers low so that we don't see any more patients or more patients in hospitals. And we need to really seriously think about how to transform our health system long term. keep patients out of hospitals, better investments in primary care, community care, long-term care. These will all be critically important going forward. The mistake we can make now is just to build back to what we had instead of to something that is hopefully better than what we had before. This is the moment, and we need, I think, to use it. There is still so much untapped potential also in how different countries treat patients. For example, I always found striking example the difference between the Netherlands and Germany. The Germans treat twice as many patients in their hospitals as the Dutch proportionally, and it's not because the Dutch are so much healthier. So that also shows, that there is a potential here to do more in primary care and keep people out of hospitals, have better treatment for people with chronic diseases. I think this is where we need to go. This is where we need to have those investments, and we need to free up time to think about how this future is going to look like, and not have the mistake that we're only focused on the backlog and the response still to the pandemic.
Very good. And maybe very briefly, Jörn or Maya, closing thoughts, maybe 30 seconds or so, just how will we balance those tensions that Ewout so helpfully laid out? Jörn, maybe you first, and I'll give Maya the final word.
Thank you. I'll just quote Winston Churchill for saying that never let a good crisis go to waste, because we have a golden opportunity to try to transform healthcare systems upon the pandemic, because we've seen things which we could try to work on, and something has to be removed from the healthcare system and perhaps being taken over by patients and citizens. Of course, we have to deal with the backlog. The Danish government had decided it has to be removed by 22 in this year, and here's the money. And we say, okay, we'll try to, but we are short on staff. So we have a national decision to remove it. But that's not transforming healthcare. That's just daily business. So back to Winston Churchill.
I knew we wouldn't get through this conversation without bringing up Churchill at least once. Maya, over to you.
For me, I think it's about, as Ewout said, about primary care, integrated care, looking at health systems holistically, and more investment. I think we should really capitalize on some of the innovations that we've seen in the last 2 years, but not at the expense of increasing health inequalities. Because I think that there's a lot of excitement about new technologies, especially digitalization, but I think we also have to be very, very focused on ensuring that everyone has access to these new technologies of digitalization, digital health. So for me, I think the most important thing is that we need to focus on addressing not only the backlog, but also the inequalities in health that have been exacerbated by this pandemic across the EU. I know in the UK and England as well, but in many European countries as well, we've seen that it's people from more disadvantaged backgrounds who've suffered the most.
Yeah, and I think that's an essential point to start to end on, is just, recovery will not be successful anywhere if we're not thinking about equity as a core facet of it and keeping that front and center. And that's been a challenge here. We've seen widening inequalities and elsewhere. So I'm really glad you mentioned it. Well, I just want to start thanking you all for such a brilliant conversation. You've been wonderful to work with, and it's been so nice to have you involved in this session. For everyone listening in, thank you for your time. This will be, if you want to revisit anything, there will be recording the session made available later on this afternoon. Please download our report. Mark provided the details earlier. And I think the one thing I'm left with is just so much of what we talked about I think a lot of the assumptions we had about what needed to happen to strengthen health systems before we even knew what the pandemic was. And I have a question of, are we really working towards something fundamentally different now, or have we known the answers all along? We just haven't really got there yet. And I think that's something I'm left with, and something we can think about moving forward. So yes, thank you again to you all for joining us. There'll be an evaluation form coming up on your screens or in your inbox later on this afternoon. Please let us know how we can make this event even better in the future. And yes, thank you, and enjoy the rest of your afternoons. And join us later for our next session on integration. I think that'll be a really good one. Okay, bye now.